My question is to the statin-loaded reconstituted HDL. So does it still bind to SRB1? So is it involved in the reverse cholesterol transport or not? And do you have any idea about the release mechanism of the statins or something like this?
Yes, it does bind. So the statin load is still, if you do it extracellularly, it still activates ABCA1, ABCG1. So yes, it binds, but the concentration is so low that the direct unloading of lipids is not a major effect. As you saw, that the RHDL per se has no protection in that particular concentration. So here it's merely the vehicle. And as to how the statin in RHDL takes care that the statin goes into the macrophage, boy, there. So we've shown that it actually, there is a transfer, but I'm not capable of explaining the actual transport, whether that's ABCA1, G1 mediated or SRB1, I don't know.
The action of the statins is so complex, you see. But I guess that there is intracellular action also, and with as the
I have a question from my laboratory point of view to my colleagues clinicians. Do you think that the laboratory methods may be replaced by imaging methods? Because I have an impression that clinicians are mostly focused on imaging atherosclerotic plaque, and they don't remember that taking blood and sampling blood is much easier to analyze, to diagnose patients.
Possible answer. No, a possible answer could be the microparticles. They are very important for such a diagnostic approach. Don't forget that the microparticles, the microdust in blood, is very important. You mentioned these fissures at the plaque shoulder where the bleeding occurs, and if you have very much microparticles, a high content of microparticles in blood, the event will become more worse. And so determining the microparticles in blood, it is possible. It's a diagnostic test. We have some clotting tests for microparticles, and possibly more better with the effects, what you showed with this method would be very important. And don't forget, microparticles are also coming from the macrophages. They are shedded from the activated macrophages, and so if you have high content of microparticles in blood, it's really a dangerous symptom.
No one forgets that it's easy to withdraw blood, but if you look at the humongous amount of money that has been invested in combining 20, 30, 40 inflammatory biomarkers and see whether you can add predictive power, and basically it all was very, very modest. So the discriminative value of adding multiple biomarkers which are currently available has basically now been abandoned. I completely agree that maybe we can come up with a much better biomarker like the particles, but I think you can imagine that based on our high expectations of inflammatory biomarkers and the very, very meager results, not adding to current cardiovascular risk engines, has dampened the expectation to some extent until a really good biomarker comes by. But to date, I would say biomarkers, not that promising yet.
maybe we should change the definition of laboratory biomarker. They are not only proteins, but we can also look for another compounds like microRNA, for example. So there is a lot of spectra of biomolecules which can be used in biomarking of disease.
You also have to discriminate between soluble biomarkers in the circulation and local biomarkers, because everybody knows his cholesterol, but the only cholesterol which is relevant is the cholesterol in your vascular wall. So it's the same thing, but it's at a different place. So maybe this question of non-invasive imaging really is something that I believe that this is something that really will add to our understanding. So one significant effort should certainly be to advance in non-invasive or invasive, just in molecular imaging for atherosclerosis.
This is exactly the point what I wanted also to mention. We have in the asymptomatic subclinical patient find the vulnerable lesions which are non-stenotic, and so this is a very important task from nanoarteria also, to find an intelligent undercut contrast agent identifying the amount of vulnerable lesions. This would help more to say, okay, this is our candidate where we have to start with preclinical therapy. And so we really have to identify within the scenario these vulnerable lesions. And there are existing, they are non-stenotic, and we cannot find it with the available methods. And so this molecular targeting of the perpetuated for future culprit lesion is very important.
Okay, so let's avoid cold coffee and drink it hot, which is outside now.